Hello, everyone. My name is Benard Miregwa, and I'm very excited to be among the presenters for this part of conference 2021. Indeed, interesting times whereby we have to present from our living spaces and or from our offices. And I'm excited specifically to take us through this conversation based on the study that we conducted titled The Impact of OHI plus Universal Pharmacare on Prescription Drug Use and Costs Among Children and Youth under 25 years in Ontario, which is a time series analysis. And the subject is very salient and timely. Following that, it will inform the key conversations that are ongoing at the national front on national pharmacare. And evidence has shown that universal pharmacare has shown to promote necessary care and protect patients from financial hardship. And drug insurance specifically have enhanced universal access to essential prescription treatments, which may improve the medication adherence, though the effects on patient clinical outcomes and overall healthcare costs is mixed. And specifically with comparing Canada with other developed economies, there's a very ugly comparison and exception because most of the developed economies have implemented prescription drugs within coverage within their healthcare insurance systems, with the exception of Canada, where prescription drugs are currently funded by fragmented patchwork of public and private drug plans that vary between provinces in Canada. And this has left most Canadians with little or no drug coverage at all. And the most susceptible population that is disadvantaged with this patchwork system has been children and the youth. And limited studies have investigated the status of the coverage variation. And it is to this effect that the province of Ontario in January of 2018 decided to adopt or implement a universal pharmacare program, Ontario Health Insurance Plan Plus, policy that covers residents below 25 years that also encompassed about more than 4,000 medications in the Ontario Drug Benefit formulary. However, the enhanced OHI Plus model that was implemented was modified following the new government that came into office to a more restrictive model mandating the use of private insurance. Since then, no study has really assessed the impact of Ontario OHI Plus plan on rates of medication use and drug expenditure, comparing the same with a relevant Canadian jurisdiction. In order to fill this gap in literature, we conducted this study with our primary objective being to assess the number of publicly covered drug prescriptions and plan expenditures before and after the implementation and modification of OHI Plus in Ontario, and then comparing that with British Columbia. Our specific aims overall, we wanted to assess the drug utilization and costs, and then we did a sub-analysis for ATC level 5 for specific ingredients, asthma and diabetes, drug plan utilization and expenditure, and see how the trends vary over the study period. We retrieved data from the CAE, National Prescription Drug Utilization Data Sources, that had encompassed data from 2016 to 2019, and our exposure group or intervention group was Ontario, where implementation and modification of OHI Plus policy happened. And the control group are all BC drug plans where prescription use and drug expenditure was stable over the study period. Our cohort focused on residents below 25 years of age, which are children and youth accessing free drug prescription coverage that are within the province of Ontario and BC. The outcomes of interest were public drug plan utilization and expenditure, and also the timeline that we encompass were 24 months before and 15 months after the OHI Plus policy implementation, and also had a 7 months follow-up after the OHI Plus policy modification. The analysis we made use of were interrupted time series design, and the results that we retrieved at the end, our cohort averaged overall about 260,000 beneficiaries per month for Ontario, and for BC was about 120,000 beneficiaries per month. Comparing BC and Ontario, BC, the utilization stayed stable over the study period, but for Ontario, the pre-post implementation utilization, an increase of 74%. Mean overall rates. Putting it in numbers, it's the rate before the implementation was about 76,000 per 100,000 prescription per person per population. And after the implementation, it jumped to 295,000 per 100,000 prescription per person per population, which after the modification, we saw a drop of about 50%, which dropped the mean overall rate from 295,000 to 142,000 per 100,000 per prescription per person per population. For the sub-analysis, we saw quite a significant jump, the pre-post policy implementation period of about 500% mean monthly asthma prescription rates. And for diabetes was above 200 mean monthly diabetes prescription. And both asthma and diabetes after the modification saw a decrease that was above 50%, which was significant. For individual use, the highest individual ingredients, ATC level 5, the drug class that had the highest increase change, the pre-post implementation phase were biologics, especially omalizumab and corticosteroids for asthma. And diabetes, we saw the highest increase for sodium glucose co-transporter 2 inhibitors, specifically for empagliflozins and insulins. For after the modification, we also saw the highest decrease by corticosteroids, and for diabetes, the highest decrease was for insulins. Drug expenditures also showed similar results, which increased from 189 million Canadian dollars in 2017 and to 671 million Canadian dollars in 2018, which is almost 4 times increase, and then decreased after the modification to 204 million Canadian dollars in 2019. The pre-post adoption expenditure also had significant changes, above 200% increase, but also after the modification, we saw a decrease of about 99 mean overall rates. For drug utilization, we see this graph shows a very interesting jump. We found a level increase of 2.13 monthly public covered prescription per person per population paid for by the plans at the implementation phase, that also decreased at the second phase of modification to 1.61. And we also saw the second graph for drug expenditure also had a very significant increased monthly plan expenditure of about $115 per person per population after the adoption of OHI Plus. That also after the second phase change, we saw the decline by $99 per person per population. The two models had very interesting effects, and the key messages we get from these, we provide the fast analysis of the impact of implementing OHI Plus, which is key to informing the ongoing discussion of the national front on national pharmacare, and adopting a universal pharmacare model so as have a very significant increase in publicly covered prescription and plan expenditures. After modifying, we also saw decrease in publicly covered prescription and plan expenditures. And this study provides fast real evidence from the Canadian context on expected volumes and plan expenditures for national pharmacare for this group, and features research should examine associations of changes in policy with health outcomes, including impacts on private plans, out-of-pocket payments. I want to take this time to appreciate, on conclusion, appreciate Lawrence, Joanne, Florence, Joab for their help to pull through this presentation. Also the CAE and BTWISE team for giving us the data that we analyzed. Special thanks goes to Drs. Holbrook, Lowe, Lavis, Stebane, Dorofish, Wilson, and the research team and sponsors for their support and contributions. If you want, you can reach us at miregwa@mcmaster.ca. Any questions, I'm happy to take, and thank you so much for this opportunity.